Good afternoon. We're called to order. Thank you for joining us. I'm Representative Jim Dunnigan from Utah. I also chair the NCOIL Health Insurance and Long-Term Care Issues Committee, and I'll be moderating this general session. We have a great panel of speakers with us here today to discuss a very timely issue. It's going to be an interesting topic, the latest development surrounding weight loss drugs. Some of you may recall that we had a session on this issue back in the summer of 2021, and that was when the FDA had just approved Wegovy for chronic weight management in adults with obesity or those overweight with at least one weight-related condition such as high blood pressure, type 2 diabetes, or high cholesterol. Fast forward a few years, and now this is an issue that you seemingly cannot go a day without hearing about. For example, in the last few months, we've seen the following headlines. North Carolina, the state health plan, ending coverage for weight loss drugs due to rising costs. Medicare announcing that it will cover weight loss drugs for patients at risk of stroke or heart attack, and Eli Lilly's weight loss drugs facing supply crunches as demand for them soars. And most recently, we saw Costco announcing that they were going to provide some access to the drugs, but that they were in limited supply and might not be available. Given this flurry of activity, now is a great time to discuss the development surrounding access, cost, and coverage of these weight loss drugs, and consider what we as policymakers and our constituents need to be aware of. Let me introduce our guests and our panel today. We have Julia Nolan. She's a patient who has used these medications. Christy Gallagher, Research Project Director at the Stop Obesity Alliance. We have James Gelfand, President and CEO of the ERISA Industry Committee. And many thanks to James, who adjusted his schedule to fill in for his colleague, Melissa, who couldn't be here today. We have Kristen Niakan, Senior Pharmacy Benefits Analytics Manager at Milliman, and Randy Pate, former Deputy Administrator and Director at the Center for Consumer Information and Insurance Oversight at the Centers for Medicare and Medicaid Services. To learn more about the speakers, you can view their bios in the program and also on the app, and I encourage you to reach out to them afterwards and learn more about them and these important issues. Also included in the materials for this session on the app and website is an economic impact study and a fact sheet submitted by Global Data. In terms of format, we'll hold our questions until the end. Let's get started. First, we'll hear from Julia. Please go ahead.
Hi there. As he said, my name is Julia Nolan. I am a patient on Wegovy. I have started on Wegovy in 2022, and I've lost a total of 70 pounds, and I'm now continuing the medication for maintenance purposes. I have spent my life as a professional singer and performer and have never had a weight problem until I started on fertility medication to get my boys. And I started noticing I wouldn't necessarily equate it to the fertility drugs, but I just noticed with hormonal changes and lots of different things going on in my body, I did start to put on weight. And I have honestly been through every type of weight loss therapy, medications, nutritionist, and I, again, go back to my life as a professional performer. I've been extremely active my entire life, and I have 3 boys, like I mentioned, so I'm still extremely active. I'm a children's theater director. I work with 40 to 60 to 100 children on a daily basis, so I'm always up choreographing and being with young people. I'm not just sedentary and just sitting around doing nothing and eating all day. I really actually like to eat very healthy, and I like to be active and physically healthy. So I couldn't quite understand what was happening with my body and why I continued to gain weight and could do nothing to get the weight off. I have done HCG, I have done phentermine, I like I said, I've had nutritionists, I've had personal trainers, I've gone to the gym, I still have a gym membership, and I would usually lose about 7 to 12 pounds, and I would think, yay, something's finally happening, and then I would continue doing what I thought I was supposed to be doing by eating well and exercising, and I would gain back the weight, and usually double the weight. And so I went from, this 10 pounds, and then 20 pounds, and then 30 pounds, and then lo and behold, I look back at pictures of myself and I think, oh my goodness, that I actually look like I'm wearing a fat suit. So I had this kind of strange body dysmorphia. I was starting to get honestly depressed. I've never had any type of depression issues. I've always been very happy and upbeat. And my husband said, I think you might need to start talking to a doctor. Well, because I've primarily been very healthy, I think only until I had my children did I have my blood labs drawn. I finally went and got a primary health care doctor, and they did my panel, and my whole thing lit up in the reds. And she said, we're going to have to get you on cholesterol medication. We're going to have to get you on high blood pressure medication. I've never had problems with my blood pressure. I've always been very low. And I was like, well, let me try really hard. I can do it. And so, again, I tried to do what I thought was the best thing for me with the eating healthy and exercising. I went back a year later crying, and we've got it. Oh, then I was diagnosed with sleep apnea, and my husband would no longer sleep next to me, and he made me go to the other room. And I was like, okay, this is just getting out of control. We've really got to do something about this. And so I had a CPAP, I had high blood pressure, I had high cholesterol, and not to mention the physical issues with joints and back pain and all of this stuff. And so I finally went to my doctor in tears, and I said, there's got to be something else I can do. And lo and behold, the FDA had just approved a weight loss medication, and I said, yes, let's try it. And quite honestly, it was a lot of jumping through hoops. She would blame the insurance, and the insurance would blame the doctor, and the doctor would blame the pharmacy, and it kind of just kept going in circles, and I couldn't seem to get a hold of this medication. And she said, I'm going to be honest, no insurance ever covers this. And I've had plenty of patients, and we just can't seem to get it pushed through to insurance. And I said, will you please let me try? Like, just please write me the prescription, and let's see what we can do. Let's see if anybody will accept it, and we can get this pushed through. Once it showed on my blood panel that I was obese, it was not an option for me to continue down that path. Obese was for other people, not for me. And so when I started seeing that my BMI was, now I'm in the obesity category, and I have 3 young children at home, and I'm thinking, oh my gosh, and now I'm pre-diabetic, and I'm going to have to start taking the metformin, and then I have a thyroid issue, and then I have this, and I have all these different things that are wrong with me, and I'm going to have to be on a plethora of medications for the rest of my life. Like, this is just not going to work for me. And so finally, she agreed to writing the prescription for me, and it did honestly take a few months to get it pushed through. And thankfully, my insurance came through and was able to give me this. And so again, I have lost 70 pounds since 2022, and I have been able to maintain it. I think the best thing that I found about this medication is that it quiets the food voice. And I don't always think, ooh, honestly, I like walking in, I'm like, ooh, what's on that table? Ooh, what's over there? Ooh, are there snacks? Are there? I don't have that anymore. I don't feel that like, ooh, what's next? And like, when's the next meal coming? And what else is there like good to eat around here? I just feel like the food noise has quieted in my head. I don't have the cravings, and I feel excited about walking, and I feel good about walking, and I feel good about exercising instead of like, oh my gosh, I'm so out of breath, and it's going to be so hard for me to walk up these hills. And our family's very adventurous. Like I said, we have 3 boys, and so we love to be out in nature. We live in a beautiful area with lots of hiking and outdoor adventures. So I feel happy that I can be healthy for my children. And so the best news is that literally 2 weeks ago, I just got my blood panel done again, and I'm completely in the green. And I have no more high cholesterol, no more high blood pressure. I'm no longer on Synthroid. My thyroid miraculously healed. I don't have to have a CPAP anymore, and I don't snore anymore. So it's been a total miracle and godsend, and I'm so eternally grateful for the option to have this medication. So I think that's it.
Thank you.
Thank you.
That's wonderful. Thank you very much for sharing.
Thank you for having me.
Thank you. Okay, now we'll hear from Christy. Go ahead, Christy.
Good afternoon. I'm Christy Gallagher. I'm with the Stop Obesity Alliance at George Washington University School of Public Health. The Stop Obesity Alliance is an alliance of over 60 different organizations that have been working on the prevention and treatment of obesity for almost 15 years. So thank you very much for the opportunity to be with you this afternoon and for the opportunity to talk about the topic of obesity and access to coverage. Today I'll be talking with you about the disease of obesity, the barriers that people seeking access to care face, what obesity coverage looks like, and what the elements of a comprehensive obesity benefit are. So the American Medical Association recognized obesity as a disease in 2013, and since then, the national healthcare organizations have recognized obesity as a multifaceted, chronic disease, as well as a significant threat to public health. Obesity is defined by a body mass index, or BMI, of 30 or higher. Over 42% of the United States adults live with obesity, and obesity is a multi-organ and complex disease. According to the Obesity Medicine Association, there are at least 60 different comorbidities that are associated with the disease of obesity, including neurological, cardiovascular, psychological, urological, musculoskeletal, gastrointestinal, reproductive, and several different cancers. Now, you heard a little bit about this from Julia, but weight loss and weight gain is like a tug of war. After weight loss, the body tries to put weight back on. Although people with obesity may achieve weight loss by reducing calories and increasing physical activity, the metabolic and hormonal responses make weight loss difficult to maintain. In people with obesity, the body will try to put the weight back on for at least 12 months after weight loss. These factors explain why, for many people, willpower and lifestyle modifications alone are not enough to maintain weight loss. I want to take just a moment to talk about language. You'll notice that I use the words patient living with obesity or people living in a larger body. We try not to use the word obese any longer. We find that people who are living with the disease find that as stigmatizing and biased, and so we try and use the least stigmatized language that we can when we're talking about the disease. So clinical guidelines recommend a continuum of care to treat obesity. This comprehensive range of treatments often begins with lifestyle modification, which includes nutrition counseling, physical activity, and behavior modifications. Research shows that evidence-based lifestyle modification can lead to as much as a 5% weight loss. And before the beginning of having these anti-obesity medications, that was really great. That's what we wanted to see. But when the patient now meets the qualifications and has a BMI of 30 and above, or 28 and above with a comorbidity, lifestyle modification combined with pharmacotherapy is successful and can lead up to a 15% weight loss. Metabolic surgery is another option for patients with a BMI of over 35 or above 30 with a comorbidity, and it can lead up to a 20% weight loss or more. However, people living with the disease of obesity face multiple barriers in accessing these treatments and quality obesity care. When it comes to providers, many are just not trained. They're not trained in how to treat obesity, and they often have only been able to offer eat better, eat less, exercise more. The disease of obesity is also not taught well in medical schools. Only 7% of medical schools in the United States offer a standalone course on obesity, and only 60% integrate obesity into their other course areas. The other issue is we just don't have enough obesity specialists. Obesity medicine specialists account for only 8,300 doctors in the United States for the over 170 million people living with obesity. Other barriers include that patients with obesity don't have health insurance, or the health insurance they have doesn't cover it. Obesity care is often excluded from coverage, and when it is, it's piecemeal and dependent on a person's employer, their insurance plan, or where they live. When there is insurance for obesity treatments, patients often face hurdles that they must meet prior to approval, and even then, the treatments are not affordable. So at the Stop Obesity Alliance, we've been researching coverage of obesity treatments since 2009 in state Medicaid and state employee health plans. Our most recent publication was on state employee health plan coverage in 2020 and 2021, where we looked at the coverage of screening and counseling, nutrition therapy, pharmacotherapy, and surgery. You can learn more about what we found and how your state compares to other states on our website. But I do want to point out that this research was done before the advent of these new recent drug therapies, these popular GLP-1 medications were approved. We do have some exciting news, and by the end of May, we will be releasing new data on state Medicaid coverage and what that looks like across the United States. Our research on what coverage existed has led us to developing what we recommend should be included as a comprehensive obesity care benefit for health plans. This benefit follows evidence-based recommendations from medical guidelines for obesity treatment and supports clinically significant weight loss at 5% reduction in body weight. I'll just quickly run through the elements of the benefit. All patients should be screened annually for obesity. Following the United States Preventative Task Force recommendations, for patients with a diagnosis of obesity, they should be referred to intensive lifestyle intervention and screened for obesity-related complications. Intensive behavioral therapy programs should offer a cognitive behavior change component, a physical activity component, and a nutrition counseling component. And all FDA-approved medications for the treatment of chronic weight management prescribed in conjunction with behavioral interventions should be covered. This includes short-term medications like phentermine and long-term anti-obesity medications like the new Wegovy and Zepbound. In addition, health plans should authorize coverage for alternative medications for people living with obesity so that additional weight gain is avoided. There are so many medications out there that actually cause people to gain weight. Finally, metabolic surgery should be covered along with revisional procedures to correct any complications or when inadequate weight loss is not achieved, even though people follow the instructions. So I often get asked, are there any real-world examples of what this looks like in the real world? Well, the answer is yes. The Office of Personnel Management, who provides the guidance to the federal employees' health plans, instructed them in their carrier letters in 2022 to offer each element in our benefit to their employees, including intensive behavioral therapy, all anti-obesity medications, and surgery. This went into effect in 2023, and we're anxiously awaiting the results of what that looked like for their beneficiaries last year. We put together a comprehensive obesity care benefit checklist. It's on our website, so you can look at and review it and see what your state currently offers and even what your personal health insurance offers. I just warn you, you have to look really hard. The words diet, obesity, obese, weight are all the words that you have to search in order to figure out what is available in your health plan. So beyond the health of your constituents, it is important to treat obesity for the health of your state's economy. Obesity dramatically reduces economic activity, largely driven by health-related absenteeism, disability costs, fewer adults in the workforce, as well as increased healthcare costs. The organization Global Data, who I understand from your opening remarks also submitted some research, has done this thorough economic analysis for several states, and it goes into much greater detail. It's all available on their website. And for those states that they have not completed an analysis for, they have a model that you can use. So once again, I want to thank you for your time this afternoon and for the opportunity to talk with you. In conclusion, I really hope that you take away from my comments that obesity is a disease that deserves treatment just like any other disease, both for the patients who are living it, as well as for the impact that obesity has on the economic activity of your state. Our goal in sharing what we have learned about coverage is for you to consider offering this comprehensive obesity benefit, and it should be used as a model for the coverage that you offer to both state Medicaid and state employee health plans. Thank you again for your time this afternoon, and here's my contact information if you have any further questions.
Christy, that was great. Thank you very much. A lot of good information. Okay, James, go ahead.
Thank you. Good afternoon. I'm James Gelfin, President and CEO of the ERISA Industry Committee, or ERIC for short. We are a trade association in Washington, D.C., representing about 100 of the nation's largest employers in their capacity as sponsors of benefits plans. Our member companies are in every industry and sector, every state, every city, every congressional district. We represent them before Congress and the federal agencies and state and local governments, advocating for laws and policies that improve the quality and affordability of benefits, reduce administrative burdens, and support employer-sponsored benefits. I'm pretty sure that I'm here today as the designated troglodyte, but I will be talking to all of you about GLP-1s. As you undoubtedly know, more than 160 million Americans are enrolled in employer-sponsored coverage, with over 110 million of them in self-insured plans in which the employer pays medical costs on behalf of beneficiaries rather than just purchasing an insurance policy. Employer plans offer the most comprehensive coverage at the most competitive prices, and many employees' premiums are highly subsidized by their employers. Federal law essentially requires large employers to subsidize coverage at about 60% or face penalties, but most of ERIC's member companies offer much richer benefits, paying about 75 to 80% of healthcare costs on behalf of employees, their families, and sometimes retirees as well, especially in unionized workforces. Many times these benefits are the subject of collective bargaining agreements and are a prized benefit. But as healthcare costs continue to rise faster than the economy grows, employers and unions have to make tough choices, sometimes choices about premiums, deductibles, and copays or coinsurance, and sometimes choices about limiting coverage for certain treatments or providers. The story's a little bit different for small businesses who often struggle to afford coverage for employees at all, and who are generally not under any legal obligation to do so. A recent poll from the Small Business Majority found that 78% of small businesses who do currently offer coverage say that their premiums are rising faster than they can keep up with. And these increases are so fast that 1 in 4, 25% of those small businesses say that they will drop coverage. At the same time, most of these small businesses are subject to state laws, so that every time a new state mandate passes and their premiums inch up just a little bit faster than they already were, you're seeing coverage drop. You're seeing those employees and families migrate into Medicaid or into subsidized ACA plans. I don't know if any of you are considering state mandates to cover weight loss drugs, whether under the guise of pre-diabetic or other conditions, but if you do, I hope that your state budget is flush with cash to support your Medicaid program and help your hospitals with increased uncompensated care. Talking specifically about these weight loss drugs, there is an extreme need for them. America does have an obesity epidemic, and employers recognize that. In 2020, NIH reported that CDC estimates were 43% of Americans were obese and another 31% were overweight. So that's 3/4 of the country who could be on these medications. The opportunity in volume is literally insane. So the drug companies came to a fork in the road. They could go for moderate profits at a very high volume or super high profits at a much lower volume. And I think that you all know which route they did take. I have a chart from Axios. As of August 2023, the price of Ozempic in the United States was $936 per month. That same medication was $169 in Japan, $147 in Canada, $144 in Switzerland, $103 in Germany and the Netherlands, $96 in Sweden, $93 in the UK, $87 in Australia, $83 a month in France. So we're paying 10 times as much for those drugs. And we're not talking about Ghana or the Sultanship of Bhutan here. These are industrialized, wealthy nations that can afford to pay for healthcare for their citizens. Perhaps these differences are why the United States Senate Help Committee chairman is outraged that these drugs apparently cost about $5 a month to manufacture. So what is the strategy that we are seeing from drug manufacturers to obtain coverage? Well, the elements include first, a massive marketing campaign. Not only are Oprah, Kim Kardashian, and Elon Musk, and tons of other celebrities and online influencers talking about these drugs, but check the Physicians Sunshine database next year. Drug manufacturers are pushing these through providers very hard. They are also said to be weaponizing patient assistance programs. We know that these programs are very profitable for drug makers because they push patients through the deductible and out-of-pocket max, so the employer then shoulders all healthcare costs on behalf of an individual. What we are increasingly hearing is that patients who get these discount coupons for these drugs find that the coupons are evaporating in the middle of a plan year. I assume that the objective then is to get the patient to desperately call their HR department or insurer for continued assistance, knowing that the plan does not actually offer the generous coverage that they received under the coupon. There's also a new cottage industry of online charlatan prescribers. You give them your insurance info, they give you whatever prescription you need to meet the criteria in there. We have deep concerns, not just about fraudulent nature of some of these providers, but this kind of online pill mill, or maybe it's a needle mill in this case, they can be downright dangerous for patients. And anyone who can be bought has been bought. Patient groups, nonprofits, even some employer groups, and especially politicians. There are now nearly 100 members of the House of Representatives and 22 senators who have signed on to legislation to require Medicare to cover these drugs. That bill, if passed, will bankrupt Medicare. If Congress does decide to pass this bill, my prediction is that they will pass it in such a way that they change the effective date to when those drugs are subject to mandated government negotiations. And that might be a way that they try to mitigate those costs to Medicare and not bankrupt it immediately. Now, what do we know about the patients who are using these drugs today and how it's working out for them? First off, it's important to note the primary users tend to be females in their 30s to mid-40s with no history of heart disease, which is an important point because a huge amount of hype was generated around a study supporting GLP-1s for heart health. But the participants in that study were in their 60s and had serious heart problems, and by the way, 70% of them were men. Adherence to these drugs is bad. 60 to 80% of users don't make it through a year. That's a problem because it takes time to get results, maybe a year to start to see the big results touted on TV, and once medication stops, the weight generally comes back, according to the drug company's data. We are also hearing that the side effects are worse than what was initially reported. Apparently, the mechanism of action is such that it doesn't just make you less hungry, but it's some kind of gut paralysis that is implemented. Many patients report severe stomach and intestinal issues when taking the drugs. Eric has canvassed our large employer member companies and reviewed market analysis to look at the prevalence and nature of employer plans' coverage of these drugs. And what we found is that despite reports of large numbers of employers covering the drugs, most who do highly restrict access to them. Restrictions might include limiting to those with severe diabetes or specific BMI parameters. Most plans will impose step therapy or require behavioral counseling or exercise programs and more. And in the end, coverage right now is very rare, with few employees qualifying on most employer plans. We also asked employers if they were enthused by new indications of benefits to heart health and the like. They responded that employers already knew that losing weight helps with a host of conditions, so additional clinical indications like that will likely not be persuasive in coverage decisions. In fact, they expect many such new indications in the coming years. We did hear from some employers who have so-called open formularies, which means that they allow access to newly approved drugs basically on autopilot. And what we heard from those employers was that the costs have been disastrous for them. Benefits consulting company Lockton found that for most employers who covered these drugs, they quickly soared to their top 5 most expensive health plan costs within 90 days of initiating coverage. Not top 5 drug costs, top 5 costs in their entire health plan. We heard from one of our member companies that when the worksite health clinic at one of their factories prescribed these drugs to a single patient, word of mouth spread like wildfire, and the cost quickly overwhelmed the plan. This took place in the latter parts of 2023. They ended coverage of this class of drugs on January 1st of this year. Employers also did not report cost savings. They reported increased use in anti-nausea medications and increased ER visits, both attributable to individuals with those scripts. I imagine you are all very familiar with the situation in North Carolina with their state employees as well. North Carolina State Employee Plan spent $50 million on these drugs in 6 months in 2022. In 2023, they spent $100 million on these drugs. They projected that it would increase to $1 billion within 6 years. For 2024, they wanted to pump the brakes on new prescriptions. The manufacturer said, fine, then you will get no rebates for those prescriptions that you do cover. This would have raised their expected costs for the year, which were already expected to be $170 million, by an additional $54 million. So the plan stopped covering the drugs. But think about that for a minute. The drug company essentially chose to incinerate $170 million per year rather than allow restrictions on the number of scripts that were going to be written. So, what is the outlook of employer coverage of these GLP-1s? Many are asking if employers will cover these drugs in the future. I think the answer is not at their current prices, and not if the manufacturers are going to retaliate for the imposition of medical management or other cost control measures. It doesn't matter how many billions of dollars are spent on advertising or lobbying campaigns or AstroTurf, et cetera. Employers are plan fiduciaries. We're responsible for making these plans affordable for the people who work for us. Our member companies have to balance the care provided with the funds that are available. They have a duty not to pay unreasonable fees and to act in the best interest of all the plan beneficiaries. The tragedy is that our member companies actually do want to cover these drugs. They think there are a huge amount of beneficiaries who have the potential to be helped by them. But decisions made by the drug companies are basically making it impossible, and patients will likely suffer because of that. But we hope the situation will improve in the future. We hope that as more drugs come online and more competition takes place in the market, there may be new options for patients as well as employers. So thanks for the opportunity to participate today, and I look forward to any questions.
Thank you, James. Kristen, go ahead.
Thanks. My name is Kristen Niakon. I'm a pharmacy management consultant with Milliman.
Go ahead and pull that mic a little bit closer to you.
Okay. Hi, my name is Kristen Niakon. I'm a pharmacy management consultant with Milliman, and although I am not an actuary, I certainly worked with a lot of actuaries on this framework as well as this analysis, which is looking at the impact of healthcare costs resulting from anti-obesity medication coverage, specifically in the commercial and Medicaid markets. Okay. So first we'll get into some background. What does the current state of coverage look like in Medicaid and the commercial market? So state Medicaid programs do not currently have to cover anti-obesity medications, but we know of at least 12 states that offer coverage of GLP-1 anti-obesity medications. And we know of at least 2 states that are anticipated to add coverage this year. There are an additional 4 states that provide non-GLP-1 anti-obesity medications, so drugs like Contrave or Phentermine. And then it's estimated that approximately 43% of commercial plans cover anti-obesity medications. In our analysis, we relied on 2 large data sets. For the commercial population, we used Milliman's proprietary claims database. This database includes both claims and enrollment data for over 60 million members annually, commercially insured members. And we have data through the 3rd quarter of 2023. For Medicaid, we relied on the TMSIS data set from CMS. This is a very comprehensive data set that captures claims and enrollment data from all members in Medicaid and CHIP. We have data through 2022, so a little bit later. As a result, we also supplemented with state drug utilization data from Medicaid.gov. As the name implies, this is drug utilization data by state, and the data is available through the third quarter of 2023. That really informed some of our market share assumptions. So here we have a framework on this slide and the next few slides to how we approached estimating the impact of adding anti-obesity medication coverage. First, we wanted to look at, well, what is the eligible population? Who's eligible to take these drugs? So we aligned with the FDA label, including patients with obesity, as well as patients with, who are overweight with an obesity-related diagnosis. Because GLP-1s are also approved for other indications like type 2 diabetes and recently cardiovascular disease, we excluded those members from our eligible population. These drugs are also being studied for other indications, and so we excluded chronic kidney disease and NASH, as these are anticipated to be approved in our study period, which was from 2025 to 2029. Then we asked, well, of the members who are eligible, what does uptake look like? How many people are actually initiating therapy who are eligible? To do this, we reviewed claims data again and calculated of those who are eligible, what percent are actually initiating therapy, specifically in state Medicaid programs that already offer coverage and on plans that offer coverage. So when we multiplied these two factors together, we are seeing that in the commercial market, there are about 0.9% of adults projected to initiate anti-obesity medication therapy. And in Medicaid, that was 0.4% of adults. And I'll specifically call out that it was adults because when we looked at the pediatric population, the uptake was much lower. Some of the other key assumptions used in our analysis was market share distribution. So there's a variety of anti-obesity medications on the market, both GLP-1s and non-GLP-1s, which have different price points. As such, we wanted to make sure that we accounted for the market share distribution. In the commercial marketplace, we are seeing about 85% of the market share was made up of GLP-1s, and 94% of the Medicaid market share was made up of GLP-1s. We also accounted for medications that had recently launched, like, for example, Zepbound launched in the fourth quarter of 2023, so that wasn't reflected in our data, but we did account for it. And then we also accounted for patent expiration. So any drugs going projected to go generic in our time frame. We also asked, okay, so for those individuals who initiate therapy, how many scripts per year are those members receiving? Again, we relied on the claims data for this assumption. And we observed an average of 6.1 scripts per year per patient in the commercial market. There's slightly lower adherence in the Medicaid market, so there was an average of 5.4 scripts per year. If you don't have access to data for anti-obesity medications, you could also rely on analogs such as Ozempic or Trulicity, which are GLP-1s approved for type 2 diabetes. We also segmented the population into an adherent and non-adherent population. For the adherent population, we assumed that those members would get 9 scripts per year, whereas the non-adherent population would receive 2 scripts per year. This is a really key consideration because it is only the adherent members where we would assume any sort of healthcare cost offsets. So if you're adherent to your medication, we'd assume you're, observing weight loss and would therefore have decreased healthcare utilization. So we would not assume any cost offsets for the non-adherent patients. These are our last two key assumptions in our modeling. The gross and net cost of the drug. So for the gross cost, we use the wholesale acquisition cost. You can kind of think of this as the MSRP of the drug. We got that from Metaspan. And then we accounted for the net cost of the drug. So because this is a competitive market basket, we assumed that there would be negative net cost trends year over year in line with other therapeutic classes with competition. We calculated the Medicaid rebates based on statutory rebates from the Medicaid drug rebate program. One consideration is if you're a state Medicaid program, you may also be eligible for supplemental rebates. The net plan liability that we used in our analysis was $300 to $400 per month for commercial GLP-1 anti-obesity medications, and that accounted for both the patient cost sharing as well as rebates. And then the last assumption was healthcare cost offsets. So as I mentioned previously, members who are adherent to medications are more likely to observe weight loss, and we would expect that to result in a decrease in healthcare utilization, which would result in savings for a state Medicaid or health plan. For this assumption, we relied on literature. We did not assume any savings for a pediatric population, so the 12 to 17-year-olds who meet some of the label criteria for some of these products, as the study that we relied on was not studied in a pediatric population. Also, in Medicaid, for the dual eligible members, those members who are eligible for both Medicaid and Medicare, we did not assume any healthcare cost offsets because under current legislation, Medicare generally doesn't cover anti-obesity medications. So Medicaid would be paying for the cost of the drug. Any healthcare cost offsets would then be experienced by Medicare, largely. So we observed about 14% cost offsets, and that's across like the medical and pharmacy benefit in the commercial market, and 6 to 12% in Medicaid. We did assume lower cost offsets in the Medicaid population due to some unique socioeconomic and social determinants of health dynamics in that population. Now getting down to the numbers. Here we have the results from our analysis. Again, this was a 5-year projection from 2025 to 2029, looking across the commercial market in green at the top of the slide, and then the Medicaid market at the bottom in blue. We have 2 scenarios presented with and without healthcare cost offsets. We have the gross cost at the top of the table, the net cost in the middle, and then we have the stakeholder impacts broken out. So in the commercial market, the 2 stakeholders that we're considering are the member and the plan. We assumed 11% average cost sharing for the member. And then the plan liability is the gross cost minus the member paid minus rebates. In Medicaid, our 2 stakeholders are the state and federal government. We conducted this analysis on the state level, accounting for the state-specific federal match. We also conducted this analysis on the population level, accounting for populations such as the Medicaid expansion population that receives an enhanced federal match. You can see that the cost estimates are lower in the Medicaid population. This is largely due to the higher proportion of children in that population. And just a few considerations when evaluating the impact of adding anti-obesity medication coverage. You'll want to ensure that you have a sufficient data source or that you can rely on analogs in your data. You want to be mindful of indication changes, so currently approved indications like type 2 diabetes and cardiovascular disease, as well as any future anticipated indications of those products. You want to be considering market events, any new entrants to the market. So for example, we accounted for the launch of Zepbound in the fourth quarter of 2023, as well as any patent loss or loss of exclusivity, drugs going generic. And lastly, you'll want to consider cost offsets and your unique population characteristics. Thank you.
Thank you, Kristen. Randy, go ahead.
Oops. Here we go. Thank you, Mr. Chairman. Really appreciate it. My name is Randy Pate. I'm in private consulting. Actually worked with Novo Nordisk on developing my remarks, but they are my own today. And I'm formerly with CMS. I was Deputy Administrator and Director for the Center for Consumer Information Insurance Oversight. And I was actually also at the 2021 panel that was held here at INQUIL back when Wegovy was first approved for obesity. And it's a much hotter topic than it was a couple years ago, and there's a lot going on, so I'm excited to be here to talk to you today. So we've already heard a lot about the price tag of obesity for our nation. In 2019 alone, obesity-related healthcare costs were estimated at a whopping $173 billion per year. Medical costs for adults with obesity average about $2,500 a year higher than those with normal weight. And for those with severe obesity of 35 BMI or higher, the annual costs skyrocket to nearly $6,000 a year higher. But the costs of obesity extend far beyond direct medical expenses, as we know. When we factor in increased job absenteeism, lower wages, and reduced probability of employment, the total economic cost of obesity has been estimated at a staggering $1.3 trillion per year. That's equal to about 7% of the entire US GDP. And I would dare to say it's not nearly that high in countries like Japan that don't have a problem like we do. As state policymakers, one of your primary concerns has to be how this impacts state budgets and taxpayers. The hard truth is obesity imposes a massive strain on government healthcare budgets. Today, nearly 7% of Medicare spending and over 8% of Medicaid spending goes towards obesity-related conditions, towards treating those conditions. If the current trends hold, obesity is projected to add about $48 billion to $66 billion a year to public health care spending. That's billions more in taxpayer dollars diverted from other priorities like education, infrastructure, and public safety to treat a largely preventable and treatable condition. As we've also already seen and heard, obesity comes with a wide array of devastating, often deadly comorbidities that are cutting short not just our lifespans, but our health spans. That is, the length of time we can expect to live a happy, active, healthy life. Obesity has been directly linked to 3 of the 4 horsemen of cardiovascular disease, diabetes, cancer, and Alzheimer's disease that are plaguing our society. Before I talk about options, I want to underscore the urgency of this crisis by looking at some alarming projections for obesity rates in the coming decade. Experts predict that by 2030, just 6 years from now, a staggering half of Americans will have obesity. Even more concerning, nearly 1 in 4 Americans will have severe obesity, that's BMI 35 or higher. This means more of our citizens facing severe health risks, reduced quality of life, and higher healthcare costs. And these are the projections by income. You probably find your state here. Disproportionately affecting lower income folks by 2030, those making less than $20,000 a year who are typically on public programs. The most common BMI is going to be 35 or over. And then this is by race projections. The most common BMI you see here by 2030 for non-Hispanic Black Americans is going to be severe obesity. That's 35 or over. Obesity does not impact all communities equally. Significant racial and ethnic disparities exist, and these gaps are projected to widen in the years ahead. Currently, nearly half of African Americans and 57% of African American women are affected by obesity. The Latino population faces a similar crisis, with obesity prevalence reaching nearly 45% today, which is significantly higher than the overall U.S. population. Looking ahead, these disparities are projected to persist and even worsen. By 2030, a staggering 63% of African American women are projected to have obesity, compared to 51% of the overall female population. For Latino women, the projected rate is 58%. Among men, 52% of African Americans and 51% of Latinos are expected to have obesity by 2030, compared to 48% of the overall male population. As we've seen, obesity does disproportionately impact underserved communities, but social determinants of health also play a big part in these disparities. Factors like low high school graduation rates, higher unemployment, food insecurity, limited access to healthy foods, and lack of safe spaces for physical activity all contribute to higher obesity rates in underserved communities. And historically, obesity has been considered a personal failure and a lifestyle choice rather than a complex chronic disease. But thanks to advances in medical research, we now understand that obesity is influenced by a wide range of factors, from genetics to environment to socioeconomic status. The move away from stigma and towards a science-based view of obesity is critical, in part because it encourages people to seek medical care when they need it. It also underscores the need for a comprehensive, evidence-based approach to treatment that goes beyond simply telling people to eat less and exercise more. We've also heard earlier on this panel that effective obesity treatment requires a continuum of care, starting with screening and behavioral interventions and progressing to medical and surgical options for those who need them. This includes access to trained obesity specialists, anti-obesity medications, or AOMs, that can help regulate appetite and metabolism, and bariatric surgery for severe cases. Emerging technologies like telehealth and digital therapeutics also have the potential to extend and reach impact of obesity care. By providing access to a full range of evidence-based treatments, we can help more individuals achieve sustained weight loss and improve outcomes. Yet barriers to coverage for this condition remain. For example, while Medicare and many private insurers now cover bariatric surgery, coverage of anti-obesity medications is limited. Even when the medications are covered, prior authorization requirements and other restrictions can impede access. The lack of training in obesity medicine among primary care providers is another key barrier. Studies show that most healthcare professionals receive little to no training in obesity care, leaving them ill-equipped to have appropriate discussions with their patients. And of course, as we consider how to expand access to the full continuum of obesity treatments, we also have to address concerns about cost and utilization. Fortunately, states do have a range of workable options to strike this balance. That's the focus of a state options toolkit that I've put together, which offers nearly 40 pages of information and policy options that states can undertake to address barriers to coverage in a smart and fiscally responsible manner. So what specific policy levers can states pull to achieve this goal? One opportunity is to expand obesity coverage for state employees. As one of the largest employers in the state, states can set a powerful example and drive change in the broader market by ensuring state employee health plans cover the full range of evidence-based obesity treatments. Another option is to amend the Essential Health Benefits Benchmark Plan in the state to include comprehensive obesity care. This expands coverage to the individual and small group markets, providing access to obesity treatments for thousands of state residents. States can also pursue innovative strategies through the Affordable Care Act Section 1332 state innovation waivers. These waivers allow states to tailor their approaches to expanding coverage while offsetting costs through federal pass-through funding. Finally, states can expand obesity coverage through their Medicaid programs. By submitting state plan amendments or pursuing demonstration waivers, states can tailor coverage to specific needs of their population in Medicaid and test innovative payment and delivery models. One powerful way states can lead the charge is by ensuring your state employee health plans provide comprehensive coverage for obesity care. As one of the largest employers in the state, you have a unique opportunity to set the standard and drive change. By covering the full range, from behavioral interventions to medications to surgery, you can improve the health of your workforce, reduce absenteeism, and increase productivity. While a handful of states who have moved to cover obesity treatments have pulled back due to cost concerns, other states are showing that it's possible to balance access and affordability in obesity care. For example, Connecticut's state employee health plan covers a wide range of obesity treatments, but requires prior authorization for more expensive options like surgery. They also use a tiered approach, starting with less invasive interventions like behavioral counseling and progressing to more intensive treatments only when necessary. The bottom line is that covering comprehensive obesity care for state employees can be smart fiscal strategy. By investing in the health of your workforce, you can reduce downstream costs associated with obesity-related conditions like diabetes, heart disease, and certain cancers. Another important option for states to consider is to amend their essential health benefits benchmark plan to include comprehensive obesity care. This would expand coverage to everyone in the individual and small group markets. The ACA requires all individual and small group market plans to cover 10 essential health benefit categories. The specific services covered within those categories are determined by each state's chosen EHB benchmark plan. The process is straightforward. States can select another state's benchmark plan. They can supplement their own benchmark plan, or they even create a new benchmark plan from scratch. By taking this step, states can ensure a basic standard of obesity care for all citizens enrolled in these plans, regardless of where they get their coverage. States can also update their EHB benchmark plans annually through a process laid out by CMS. CMS recently streamlined this process significantly for states, and these changes will reduce the administrative burden on states looking to enhance their benchmarks. So far, 3 states, North Carolina, New Mexico, and North Dakota, have amended their EHB benchmark plans to expand coverage of obesity treatments. North Dakota is the most recent state to do so, and their change will go into effect for plan year 2025 in its individual market. As part of its application, North Dakota was required to submit a detailed actuarial memorandum estimating take-up rates and impact on individual market premiums. The actuarial report, which I can make available, was reviewed and approved not only by the actuaries hired by the state, but also by the CMS Office of the Actuary, and it reported an expected 52 cents per member per month premium impact for expanding coverage for anti-obesity medications. While it didn't provide specific numbers in the report, it did assume some premium savings resulting from covering the drugs. This demonstrates that states can cost-effectively offer access to needed care. For states looking to pursue even more innovative strategies, Section 1332 state innovation waivers offer a promising path forward. These waivers give flexibility to design a customized approach to expand obesity coverage while offsetting costs through federal pass-through funding. States can explore using a 1332 waiver to create a bundled or hybrid obesity treatment pilot program within the ACA marketplace. The waiver could provide enhanced subsidies for plans covering comprehensive obesity treatment with cost-sharing other plan design elements calibrated to incentivize appropriate utilization of high-value services. By coupling this with a reinsurance program, the state could offset any premium impact and potentially secure federal pass-through funding. An initial limited scale pilot could demonstrate the proof of concept for broader adoption. A key advantage of the 1332 waiver approach is the opportunity to rigorously evaluate the impact of expanding obesity coverage. By collecting data on health outcomes, utilization, and cost, states can build a stronger evidence base and pave the way for broader adoption of these strategies in the future. And then finally, we can't overlook the critical role of Medicaid in the fight against obesity. With millions of low-income Americans relying on Medicaid for their health care, ensuring this program covers a comprehensive obesity benefit is essential. One approach is to submit a state plan amendment to add coverage of obesity treatments like anti-obesity medications or intensive behavioral therapy. This is a straightforward process that can be accomplished relatively quickly and doesn't require a resource-heavy federal approval. For states seeking to test more innovative approaches, Section 1115 demonstration waivers offer a way to pilot new models of obesity care delivery and payment. For instance, states could use an 1115 waiver to establish a specialized care management program for Medicaid enrollees with obesity, providing them with enhanced care coordination and access to a wider range of treatment options. Expanding access to obesity care won't be easy, but it's a challenge we have to embrace. The health and prosperity of our state depend on it. By learning from other states, leveraging multiple policy levers, and prioritizing cost-effective, evidence-based approaches, we can take meaningful steps to make progress in the fight against obesity. And I've got my email address here, website, and the QR code will link to the toolkit and other materials. Thank you very much.
Thank you very much, Randy. I thank all of our panel. Let's go to questions. Representative Oliverson.
Sorry. Thank you, Mr. Chairman. So, a couple of things. So I work as an anesthesiologist with a lot of bariatric surgeons, so I'm not naive to the situation that we find ourselves in. And I have, like you, stressed out to a fair amount about the fact that obesity literally is the #1 health crisis facing us. But the thing that I've noticed is that all of these medical and surgical treatments are more or less temporizing, and that there are a significant number of folks, even if with surgical treatment, even when they've had part of their stomach removed, that will, without dietary changes, will gain back that significant portion of that weight, and it will be as though they got no benefit at all. In addition to that, I've been told that there are studies, I haven't seen them myself, but I've been told that there are studies that show that when you stop taking the GLP-1 inhibitors, that you pretty much immediately gain all that weight back, which probably doesn't surprise me too much considering their mechanism of action is that they delay the stomach from being able to empty, which in addition to that creates a whole host of problems for us in the operating room, because now you have people who essentially are walking around every day with a full stomach, and then when they need to have surgery, they aspirate, develop pneumonia, and sometimes die as a result. So I think we're sort of on the cusp of seeing a lot of side effects. And my question is, Randy, your presentation, I think, very conclusively demonstrated that particularly in our lower socioeconomic classes, there's a high incidence of enhanced BMI. That is, in my opinion, largely related to diet. And as you point out, social determinants of health, I think that's the right diagnosis. I mean, if you don't have access to healthy foods, if the only thing in walking distance because you don't have a car is the convenience store and all of the wonderful processed foods like, you know, unhealthy things, you're going to have poor health because you have poor nutrition. So my question is, instead of investing all of this money in a class of drugs that is undoubtedly not going to be a permanent solution to the problem, incredibly expensive, I mean incredibly expensive, why not focus on diet? Why not focus on access to healthy food? Why not prioritize making sure that health plans, particularly in the Medicaid system where we have economically disadvantaged populations, that they would have access to fresh food, even if that means literally carrying it to their house for them, and making sure they have a refrigerator to keep it cool, and making sure they know how to cook and prepare food in a healthy manner. That seems to me to be a much smarter investment than what we're talking about here, but I'd kind of like to hear your thoughts on this.
I really appreciate the question. I mean, you know, I'm talking about the total continuum of care, right? And I would not exclude from that the medication option. You know, I think you talked about the surgical option. You know, behavioral counseling is also super important to change people's relationship to food, because no matter what interventions you offer or that people use, you have to change that relationship to food, I think, to see lasting results. So it's really everything at our disposal that's been shown to move the needle, and I think that should be what we talk about when we talk about coverage for this. You know, the other thing I would say is I talked about waivers, and I really would like for states to start looking at some more creative approaches that might include, you know, issues related to social determinants of health. You know, and again, I would argue for the entire continuum of obesity treatment and coverage. And, you know, as I talk about in my toolkit, you don't have to do it statewide. You don't have to do it market-wide. You can do it in a limited area in your state. Same with an 1115 waiver. You know, an area that, hey, we want to build more sidewalks and have more parks and have more access to healthy food. But we should also look at, you know, comparing, you know, how coverage for these options, these treatments that we know work, you know, play out in the long term and evaluate those. So, I mean, I think it has to be the continuum of care. I think that, you know, we do have to, you know, address social determinants, all of these things, but I think it's super important. And as you mentioned, I mean, it's just out of hand. I'm from Alabama originally. We rank #3 in the country in obesity. It's killing our state, and it's killing a lot of us. So I think it's really important that we address it.
Christy, do you want to weigh in?
Yeah, thank you. It's a really good question, and I think what Randy was saying also, it's not an either or, it's a both and. So, for example, you have a house and it's on fire. Are you going to get rid of the smoke alarms, the fire alarms? No. But our house is literally on fire right now because of the rate of obesity in the United States. And so we need to have both of these. We need to be looking at our food. We need to look at access and so forth. The other question I would pose to you is, if someone walked into your office and needed treatment for diabetes, heart disease, blood pressure, would you tell them that they needed to go first and try and eat healthier and take care of it on their own? Or would you give them the medication that they need as well as the tools that they need to eat better and take better care of themselves? And so it's both things, and I think what happens is we have a very high stigmatized view and biased view of obesity. You know, it's people look at people who are overweight and live in a larger body as that they're lazy, that they didn't do well, and that it's something that it was a lack of willpower and lack of control. So we need to change the way that we're looking at this as a disease and provide access to care.
So I agree with you that I think the treatment is it's a comprehensive issue, but my issue with another coverage mandate for a very expensive class of drugs is that this is yet one more, cure for obesity for which there is no such thing as a quick cure. I mean, this is, as I said, you can even have part of your stomach removed, but if you don't change everything about your lifestyle and prioritize those things first, you will gain all that weight right back. The whole purpose of a gastric sleeve is to prevent you from eating so much, because it's an issue of calories in versus energy expended. I mean, that is the basic fundamental problem. Right. The problem I have with these drugs is that, just like a lot of these other treatments, they are not a permanent solution to the problem. They do not cure obesity. They are temporizing at best, and they're incredibly expensive. And so, again, I caution us because I hear from patients all the time. They're like, well, I'm on this drug, I'm losing this weight, it's great, everything's fine, life is good. Yeah, but as soon as you stop taking that drug, all that weight is going to come right back.
And as soon as someone stops taking high blood pressure medication, their blood pressure might actually go back up again.
Exactly.
And so we are at this point where we have to, if you take the cost out of the factor, then these are miraculous medications that are giving providers an actual tool to give to their patients. It decreases the food noise. It changes the hormones. So does bariatric surgery. It changes the hormones. It's not just that you have a smaller stomach. Your hormones change. You don't think about food as much. You change your relationship with food, and that's what drops the weight. So.
Okay. All right, thank you. Representative Penn.
Thank you, Mr. Chairman. And thank you for your comments, Dr. Tom. I'm a little new to this arena, and I'm sorry that I do have to get out of here, but I want to leave you with a couple of comments. In North Carolina, between 1929 and 1974, doctors going after eugenics sterilized black women at astronomical rates to say that it would help out with welfare. And what you have said today, and Ms. Julie, these comments are not for you. Your personal story is your own. But for Randy, Kristen, and Christy, absolutely terrifies me as a black man. Because what you said in your slides was that you have a target population that have obesity. And if you put them on mandated expanded coverage care, you said it was for the 1332 ACA waiver, Obamacare, Medicaid expansion, everybody gets enrolled. What I'm looking at is the impact that comes after this. Once all the taxpayers are paying for it, once all the taxpayers are paying for this, in order to stay on these health care plans that you want to expand out, you have to be compliant. One part of what your presentation was is that you think that people should have to submit to an annual review and a screening. And then to couple it with yours, black folks are going to be seen as obese. So now, to stay compliant on the health care plan, you're going to have to get a mandatory shot. That goes right back to what we're talking about, eugenics, in my book. And that's terrifying to think that we're still at that space from the 1940s where we're going to say that this big population of black folks and black women who are so obese, and they don't run any monopoly on it. I live in Kansas, there aren't many of us. You used North Dakota, which has less than a 2% black population to substantiate your claims here. All what I'm saying is, I don't see how in the world it is that we're going to propose your solution when it made no mention of personal responsibility, no mention of personal discipline, no mention of personal agency, and back to my original point, takes away free agency. There are many things, and case in point, folks, I am an obese black man, but I also know that I need to do push-aways from the table. I did 20 years in the Army, and not one soldier that I chaptered out was chaptered out because they had the discipline to do the things that were necessary and proper when they had a nutritionist assigned, when they went to classes, when they were, had extra PT organized for them. They refused to comply. It's a decision that is made. So I will not enter into the semantic playground of people living with obesity. Let's get straight to the point. There are choices that are being made, as you just heard, about what to eat, what to do. And forcing folks into a situation where they're going to take a shot in order to achieve Shangri-La, it's not there. And I would counsel this entire body to really think about the impact implications if we're going to do this, all in the name of doing some type of wealth transfer and setting it up so that people can eat from the trough, off the backs of black people. That said, thank you, Mr. Chairman. I'm going to excuse myself. Thank you.
Thank you. Do you want to respond? Go ahead. No? Okay. Go ahead.
Yeah, we're not talking about forcing anybody to take any drugs or anything like that. You know, I have family members that have been on these drugs, and you know, I don't consider them unhealthy, and I would never force, you know, anybody to do that. I think what we're trying to talk about is, you know, how do we address this problem? Because we're going to, you know, I have a family member that passed away at the age of 68 years old from a massive heart attack. And, you know, this stuff is real, it's killing us. We're not talking about, you know, trying to force people to take something. We're talking about looking at ways to address the problem so that we live longer, so that we live healthier, and hopefully that so that we don't keep having our loved ones dying an early death, you know, from obesity.
All right, thank you. Senator Marcus.
Thank you. From what I can tell, listening to what you all have presented and the reading that I've been doing about these drugs, is it seems like we've been trying to find ways to reduce obesity for decades, and that these drugs are the first thing that has worked in a dramatic way without any kind of risky surgery. And yet the reaction that we see is an increased refusal to continue to cover them. And that seems to me like we've never before seen a situation where we're refusing to provide a whole category of medication to a certain type of patient, in this case, obese patients. It feels like an interesting form of discrimination to say, we're not going to cover medication just for these types of patients because we don't think they're worthy of it, or we don't think they've worked hard enough, or whatever. And I don't think we do that with any other sort of patient, even if medications are expensive, like for cancer or other diseases, and even if those medications don't ultimately and permanently fix the medical problem that they have, as you pointed out, for high blood pressure and other things. So I think this is a great opportunity. Maybe you can answer one of the questions that has been in my mind as I think about this is, are there other examples, maybe that I'm not aware of, where entire categories of effective medications are being denied coverage, either by states or by private insurers, in the way they are for these weight loss drugs? Or is this a very unique situation in which we are just targeting obese patients and saying, just for these people, we're not going to cover what you need?
One point I would probably make is that many employer plans do cover various treatments for obesity, just not this specific class of drugs. And we exclude particular products, drugs, therapeutic mechanisms of action, et cetera, routinely throughout the entire medical surgical plans. Because when plan fiduciaries are making coverage decisions, they have to discern whether or not it's a good use of the money of the employees. Because ultimately, it's not our money. It's part of their compensation. It's their money. So when I cite a statistic like 60 to 80% of the people who are prescribed these drugs don't stay on them, and all the weight comes back, that's not just bad for the patient. It also means that the plan just wasted all the money spent on those individuals that year on that drug. So we just lost that money without accruing health benefits to the beneficiaries of the plan, right? So when we're making coverage decisions, we need to take into account the full spectrum of how this will affect a patient, and not just whether or not it can reduce the weight. We need to know if the problem is obesity, is this actually going to solve obesity? And I think you've probably heard from every panelist here that the answer is no. These drugs alone do not solve obesity. And you need to have, I think the word I keep hearing is a continuum of care, or some kind of comprehensive treatment that includes things like counseling and surgery as an option, et cetera. So, I appreciate that folks are very passionate and they want these drugs to be covered. And when they are covered, they want the plan to pay, not them out of pocket. But ultimately, those decisions have a huge effect on everybody who has insurance. And while I appreciate some of the numbers that have been talked about today, I think it would be great if these drugs only cost $400. But you heard the numbers from North Carolina, right? They paid $174 million in a year, and the rebate loss was going to be another $50 million. So that means that the rebates were not 90% or 75%, they were 20 to 25%. So that means that if the drugs are between $1,000 and $1,400 per patient per month, we're still paying drastically more than that. And so those savings figures quickly evaporate, and instead we're looking at an increased costs that are going to be borne by the families in the workforce.
Thank you. Senator Boyd.
Thank you. And before I say anything else, I do believe there are some indications for these drugs. I think that we have to figure out exactly who the patient is that benefits. But James had referred to pill mills, and I've made that same reference in committee. And while I don't think that this is a one-to-one comparison, or this is exactly the same situation that we were in with the opioid epidemic for lots of the reasons people aren't taking them and dropping over and dying. But at the same token, I do think that as industry is ramped up, there are some similarities. So one of the things with the opioid epidemic is we were told pain is the fifth vital sign. Now we're being told over and over obesity is a disease. And if we hear that over and over, we're going to believe that. So, and I'm not even going to say that I don't believe obesity isn't a disease, but I'm not sure, I don't really think it's just a choice as someone who has been obese. But at the same token, I'm not sure it's really just a disease. I mean, we can all remember the commercial, bet you can't just eat one. And I don't lie to that. That is a real thing. I mean, there are food choices, and food has its own consequences, and we've not really talked about that. So this leads me to just a couple of questions that you can answer or not. But one of the things is a Weight Watchers app is very cheap, and what that does is it helps guide people and helps them in their choices, because whatever we're going to do long term is going to have to change what people do. It's going to have to change behavior. And the drugs can help you with that, but long term, you can't afford to do that. So Weight Watchers app or Noom seems to me like it would be a low-cost barrier and a good place to start if I were, putting in a step therapy program. The other thing is, with the pricing of these medications, it's not going to stop. I mean, James again talked about what they were in other countries. So, at some point in time, if you really want to affect the pricing, you're going to have to fight back. And so what do you think about creating ordering system or, ordering them from Canada or Europe? Thank you.
So thank you. I appreciate the great discussion. I'll offer up the final question. So I've got one for Randy. If a state includes this obesity type treatment in their EHB, do they have to pay that additional cost because it's a new benefit, or the federal government pay their enhanced match?
Actually, no, they would not, because it's not considered a benefit mandate. So my toolkit, for example, I'm not advocating that states mandate benefits. The Essential Health Benefits Benchmark is something that states should be updating every so often, basically to keep pace with the pace of medical progress. And so as part of that process, states are able to look at new therapies that have come online and make those decisions, but that is different from the discussion of a mandate in statute that would be subject to defrayal under the ACA.
Okay, thank you. And Christy, I have a question. So a summary of a study I saw a couple of weeks ago indicated for these drugs we're talking about that has been mentioned they have to be taken long term. And if people go off them, then the weight comes back. But also on some of them, they're finding that the dosage has to be increased to maintain the same effect. Do you want to comment on that?
Yeah, I guess I would just say that there's still a lot of research to figure out what the long-term usage is going to look like. But we are seeing that when people go off of them, they do gain the weight back. However, I think there are drugs in the pipeline and other therapies in the pipeline that might act more as a maintenance. So once somebody gets to their healthy weight, then there may be some medications in the future that they might be able to take, or they can adjust the dosages down. I've heard of providers that will adjust the doses down, and then that helps them sort of maintain the weight. So that's still being studied. But I also just want to point out to the last gentleman spoke as well that we really do argue that these medications should be prescribed in conjunction with some type of therapy like a Weight Watchers or something similar to that. I know a lot of health plans actually have their own type of program that they offer. There's very good evidence base about intensive lifestyle programs. If you think about the diabetes prevention program, the DPP program, which was so successful, and it actually was preventing diabetes, but it was acting more as a weight loss program. And so something like that. And so even the indication by FDA is that the medication should be prescribed in conjunction with some type of intensive lifestyle therapy.
Thank you for that. And now for our final question, we'll go to Senator Gannon.
Thank you very much. So I've personally been affected. It is my fault. I have lost a leg, really, as a result recently. I chose a lifestyle. I'm too busy. I run a law firm. I want to be a state senator. I want to run the state policy. I really haven't taken care of myself. I was a 3-sport athlete. I run the Boston Marathon many times. I know better. I just haven't made it a priority in my life. So I would rather you guys than spend all the money on someone like me, because I have the ability to not eat the food. I have chosen to do too many things in my life. I would rather you put more time into the prevention. Like you talked about Japan. They're westernized. They have a changed diet. Why haven't they put on the weight? So I go into schools a lot. I've coached like 32 soccer teams. I'm at schools all the time. I see so many fat little kids. I don't mean to use that word, not a good word. But I blame the parents. I have my kids doing 3 sports. If you want to be in my family, you're doing 3 varsity sports before you get into college. And you're going to try to continue doing it in college. I try to have them do a healthy lifestyle. I see it as a family problem. I see a lot of the issues from drugs in my state. We're the #1 fentanyl problem in the country. It's family related. Education is family related. This is family related. I see the disintegration of the family as part of this big problem here. So I would like you guys to focus more on prevention in schools. That's where you'd catch them young. I'm sure there's a correlation between childhood obesity and you're going to have a much higher percent of adult obesity. So if you would work there, I think you could put the fire out before it gets to Dr. Tom. Thank you. More of a statement.
Thank you, Senator. I have an announcement for those eligible for the CIP reception, sponsors, and legislators. The designated elevator will run express from 6:15 until 6:40 p.m. from the second floor to Skype. It will bypass all the other floors. For CIP sponsors and legislative reception, the designated elevator is going to run from 6:15 to 6:40 p.m. from floor 2 to Skype. I want to thank our panelists. Thank you very much. We appreciate your joining us and sharing your knowledge and answering our questions. So up next, we have a quick networking and coffee break sponsored by Aflac. We're going to take a 5-minute break, and then we'll convene back in here for the Life Insurance and Financial Planning Committee. Motion to adjourn? Motion to adjourn. All in favor? We're stand adjourned.